Welcome all to the 19th session of vertical integration. Previous 18 episodes, there has been a lot of demands that you wanted some pictorial representation to be made. So this time we have made some changes, and let me introduce the panel for the day and also what is the topic that we are going to discuss. It is low backache. It is one of the most common causes that everyone would have at least once in your lifetime to have a lower backache. So over to my left, I have Dr. Dimple, who is assistant professor from the Department of Anatomy, and we have Dr. Jim, who is professor of orthopedics, and we have Dr. Anandaraj from the Department of Physical Medical Rehabilitation. Am I right? Because everyone have a different way of saying this. PMR department, and he is assistant professor in the Department of PMR, and we have Dr. Brubin Wright, who is the consultant from the Department of Radiology. So that is a panel. So we'll have a little bit of difference today. So we'll start off as usual with anatomy, followed by radiological investigations, what all being needed, and followed by how to do a clinical examination and what are the major red flags for the management of back pain, what that we need to anticipate specifically in an emergency room setup, and finally Dr. Anandaraj will give us an overview how to manage what are the important rehabilitation aspects for a patient with back pain. With that in background, let's start this vertical integration.
Good afternoon. I'm going to discuss on the anatomy of the lumbar spine with the clinical correlation to the back pain. So before we go into the lumbar spine, what comprises the lumbar spine? Now the lumbar spine is the lower part of the vertebral canal, which is present between the 12th thoracic vertebra and the first sacral vertebra. It comprises of the lumbar vertebra, the spinal cord, the lumbosacral segments or the lumbar segments of the spinal cord, then the muscles, ligaments, nerves in relation to it. So to start off with the lumbar vertebra, the anatomy of the lumbar vertebra, it has a body which is massive when compared to all the other vertebra of the other different levels, and it is in reniform shape. So it has a body, and then the rest of it is called as the neural arch, which is comprised of the pedicle, lamina and the articular facets with the processes. Now coming to the lumbar body of the lumbar vertebra, it has a superior and inferior surface, and there are about 5 lumbar vertebrae which is present, and it is the massive among all the vertebrae which are present, and it increases in size or the height of the lumbar vertebra increases as you go down from L1 to L5. The upper surface of the lumbar vertebra, it is attached or it communicates in between the two upper and the lower adjacent lumbar vertebra. There is presence of a intervertebral disc, which I will be talking about later. Now coming to the neural arch, the neural arch is composed of a pedicle which is present between the body and the rest of the spinous process. Posteriorly there is presence of the lamina of the lumbar vertebra, and in the lamina you have the superior and an inferior articular facet. There is presence of a superior articular facet and an inferior articular facet. Now the superior articular facet of the vertebra articulates with the inferior articular facet of the vertebra above, thereby creating a joint. This is called as the facet joint. Now in between the posterior neural arch you have what is called as the lumbar, the vertebral foramen. The vertebral foramen constitutes mainly the vertebral segment of the spinal cord and also the arteries and the veins in relation to it, along with the associated nerves. Now there is presence of a spinous process which is present posteriorly, and the tip of the spinous process gives attachment to the different muscles of the back. And there is presence of the transverse process. The difference between the transverse process of the lumbar with that of the other vertebra is the absence of a foramen transversalium in the transverse process of the lumbar vertebra. Now as we see, the lumbar vertebra are 5 in number, and in between the two lumbar vertebra you have what is called as the intervertebral disc. Now in a view which is seen in the lateral view, you can see this space which is called as the intervertebral foramen between the first and the second, or the second and the third, all the lumbar vertebra. Through the intervertebral foramen is where the lumbar nerves of that respective segment comes out. And here there is presence of normal lumbar curves, that is called as the normal curvatures of the spine. There is also presence here in the lumbar region what is called as the lumbar lordosis, which is normal. Now what is the main function of all these parts of the vertebra? The body is the more massive, and it helps in reducing the compression force and resist the compressive forces. There are pedicles which transmits the compressive forces to the vertebral body, and the presence of lamina and also the spinous process helps in the provides muscular attachment and a ligamentous attachment. The transverse process also acts as a site for attachment of the muscle and the ligaments, and the zygapophyseal facet or the Z facet is the resist compression and torsional forces. The intervertebral disc is present in between the two vertebra, and it consists of the outer annulus fibrosus and the inner nucleus pulposus. The annulus fibrosus is made up of several layers of collagen fibers and is densely compact. It is compactly arranged, and the nucleus pulposus is jelly-like material which is situated in the center. Now the main importance of the intervertebral disc is it is more thick in the front, and when it comes to the back it is more thinner, and it acts as the shock absorber of the the main function of the intervertebral disc is it acts as a shock absorber. Coming to the other structures in the lumbar spine, they are the ligaments. Now there are different ligaments which are present, which helps in providing the stability to the lumbar spine. Going one by one, you have the anterior longitudinal ligament. This ligament is longitudinally present, and it is present on the anterior surface of the adjacent lumbar vertebrae. The main function of the anterior longitudinal ligament is it avoids the extension, excessive extension towards the back. Now another ligament which is called as the posterior longitudinal ligament is also present behind the vertebral bodies, and it is present longitudinally and attaching the adjacent vertebral bodies. The third one is the ligamentum flava. The ligamentum flava is attached to the lamina of the adjacent vertebrae, and it is present more towards posteriorly and is not present anteriorly. This is the ligament which we pierce while doing a lumbar spinal anesthesia or a lumbar puncture. There are presence of other ligaments also, that is the interspinous ligaments, which is present between the spinous process of the adjacent vertebrae, and also nuchal ligaments, that's not there here. So, and also there is facet capsular ligament. The facet capsular ligament is the ligament which is present around the Z joint, okay, or the facet joint. Now what is the function of these ligaments is the anterior longitudinal ligament, it stabilizes the spine during extension or the backward bending, and the posterior longitudinal ligament, it stabilizes the spine during forward bending or the flexion of the spine. The ligamentum flava is short, paired, and it is one of the thickest ligaments which we see in the spine, entire spine. The supraspinous and the interspinous ligaments, they actually help in preventing the lateral flexion, and these are the main ligaments which undergo sprain during hyperflexion. Okay, so when there is excessive forward bending, this is the one which is most commonly injured. The intertransverse ligaments also limit lateral movement of the lumbar part. The other ligaments which are present are the iliolumbar ligaments, which provide additional support. Now coming to the iliolumbar ligament, the iliolumbar ligament is attached to the lower part of the lumbar vertebra to the iliac crest. That's why it's called as the iliolumbar ligament, and it stabilizes mainly the L5 vertebra. It is put under strain leading to back pain. When it is the ligament which is mostly put under strain when there is a long period of sitting and all that. So this is the anterior longitudinal ligament, the posterior longitudinal ligament, the interspinous ligament between the tips of the spinous processes. Now, based on the viewpoint of the stability of the spine, we divide the entire lumbar spine into anterior column, middle column, and the posterior column. The anterior column The anterior column is mainly containing the anterior longitudinal ligament, the anterior part of the annulus fibrosus of the intervertebral disc, and the anterior arch of the vertebral body. The middle column is mainly here. It comprises of the posterior longitudinal ligament, the posterior part of the annulus fibrosus, and the posterior half of the vertebral body. The posterior column consists of the bony arches, that is a neural arch here, and also your posterior that is the interspinous ligaments. Coming to the lumbar spine muscles of the lumbar spine, here we grossly divide them into posterior group, lateral group, and the anterior group. Now in the posterior set of muscles, we have the main two muscles which are involved in maintaining the stability of the lumbar spine are the erector spinae and the multifidus. The erector spinae, they are in two parts. One is the longissimus thoracis and the iliocostalis lumborum. The main function is it assists in the extension of the lumbar spine. That's the erector spinae. Now multifidus is another muscle which are present in segments, and they are short muscles. These muscles attach they are from between the sacrum and the lower part of the lumbar spine. The main action or the function of the multifidus is it controls the segmental torsion by producing compression. It produces compression and controls segmental torsion. The lateral group of muscles are the quadratus lumborum, intertransversi, interspinalis, and the rotators. The quadratus lumborum is one of the most important muscle here in this group, in the lateral group. It takes origin from the transverse process of the lumbar vertebra till your iliac crest, and when it acts bilaterally, it helps in stabilizing the hip, and when it acts unilaterally, it helps in the lateral flexion of the lumbar spine. The other small muscles which we see are the intertransversi muscles, which is attached between the two transverse processes, and the interspinalis muscle. The interspinalis muscle here, these are the spinal processes, so it is present between the two spinal processes of the adjacent vertebrae. And the rotators are also short muscles which are present here. So the function of the interspinalis and rotators is it helps in the rotation and the lateral flexion of the lumbar spine. The stability of the lumbar spine is not only by the posterior and the lateral compartment, but also by the muscles of the anterior abdominal wall. That's the anterior compartment muscles. They are the anterior abdominal wall muscles are the oblique and the transverse muscles and the rectus abdomini muscles. Also it is given, the stability is given by your quadratus lumborum and the psoas major muscle, which is present in the posterior abdominal wall. It produces stability during hip flexion. Yeah, this is already been discussed. Now coming to the innervation of the lumbar spine. To know the innervation of the lumbar spine, a quick view of the spinal cord. The spinal cord is an extension of your lower part of the medulla oblongata up until your intervertebral disc between L1 and L2. Now here the spinal cord, it has two enlargements, that's the cervical enlargement and the lumbar enlargement. These enlargements are present for producing plexuses. There are a large amount of nerve fibers in these enlargements, and they produces plexuses as the brachial plexus, and the lumbar enlargement gives rise to the lumbosacral plexus. Now the spinal cord, as we see here, it lies in the vertebral column inside the vertebral canal, and it gives rise to spinal nerves. So a spinal segment is the spinal nerves along with the part of the spinal cord is called as the spinal segment. The spinal cord is not present in the entirety of the vertebral column. Here the spinal cord ends at the junction or the intervertebral disc between L1 and L2. So beyond that, the spinal cord ends as a cone-shaped structure which is called as the conus medullaris, and from there the nerve root comes out as the chorda equina. So coming to the nerve roots, the spinal cord, each segment of the spinal cord gives rise to the spinal nerve. The spinal nerve, it has a anterior root and a posterior root, and both these roots, they join to form the spinal nerve, and the spinal nerve, it exits out of the intervertebral foramen. And one point which we need to remember is the spinal cord has 31 pairs of spinal nerves, but the length of the spinal cord, it falls short of the vertebral column. So thereby the spinal nerves exiting out of the each vertebral foramen varies from the cervical to the thoracic to the lumbar. In the cervical, the spinal nerves are run horizontally, whereas in the thoracic, as they exit out, this is the lumbar segment. But so here in the cervical region, they exit horizontally. The thoracic region, they go more obliquely. And as we come to the lumbar segments, here the spinal cord ends as the conus medullaris. So all the spinal nerves, they come as a hair of the horse tail. So that's why it's called as conus medullaris. It runs downwards, directly downwards. Now this is the spinal segment. A spinal segment is a portion of the spinal cord which gives origin to the spinal nerves. It has a ventral root and a dorsal root, and they form what is called as spinal nerve, which exits out through the intervertebral foramen. Now, as I said, there is a relative shortening of the spinal cord with that of the vertebral canal. The spinal segments and the vertebral levels, the knowledge of this is very important when we go into the clinical, for the clinical significance. Now, what is lumbar spine? Lumbar spine is the lumbar spine including the terminal end of the spinal cord and the chorda equina. The lumbar spinal nerves progressively increase in size, and the openings of these nerves and decrease in size from the lumbar spine. The nerves actually increases in size, but the intervertebral foramen decreases in size. So because of this, there are high chances of the nerve getting entrapped within the intervertebral foramen. So a plexus of nerves are formed in the lumbar region. This is called as the lumbar, and in the sacral part, when it combines with the lumbar plexus, is called as the lumbosacral plexus. Now coming to the anatomy of the lumbosacral plexus, it is situated within the substance of the psoas major muscle, and here the lumbar plexus is formed by all the four lumbar nerves, and also addition to the first lumbar nerve is the 12th thoracic nerve. Now from the lumbar plexus, it gives rise to the iliohypogastric, ilioinguinal, lateral femoral cutaneous nerve of thigh, the femoral nerve, and the obturator nerve. A twig from the L4, so this will be the lumbar plexus. Now the lumbosacral plexus is a combination of these two. So a twig from the L4 goes on to the L5, and thereby it forms, along with the L5, S1, S2, S3, S4, it forms the sacral plexus. The nerves from the sacral plexus are the main nerve, that is the sciatic nerve. Then the other nerves are the superior gluteal, inferior gluteal, and the pudendal nerves. Now, why you need to know about the lumbosacral plexus is the clinical significance which is in relation to it. If there is a impingement of or if there is herniation of the disc at any of this level, the shooting pain, which is very commonly seen, that is called as a sciatica, is present. That is because of the presence of the lumbosacral plexus and the sciatic nerve, which arises from the lumbosacral plexus L4 to S1. Radicular pain is often secondary to a compression or inflammation of the spinal nerve. So when the pain radiates down to the back of the leg or to the calf or foot, it is called as sciatica. What is a dermatome and a myotome? A dermatome is a specific area of the skin which is supplied by the spinal nerve, mainly the dorsal root fibers of the spinal nerve, and a myotome is the particular group of muscle which is supplied by the ventral root of the spinal nerve. Now, why do we need to know about the dermatome and myotome is, the L1 spinal nerve usually supplies the region of the groin and genital region. The L2, L3 and L4 usually supplies the front of the thigh and the medial aspect of the lower limb, and the L5 supplies outer aspect of the lower limb, the foot, up until the web spaces of the first and the second toe. So this correlation is very important for understanding the reason behind the low back pain, how it radiates to the lower limb. So the rest of it would be discussed in the further sessions. Thank you.
So we had a quick discussion on the anatomy of the lumbar spine. Now I have Dr. Brubin with me. So he'll be giving you an overview of what are the radiological investigations and basic modalities. Why you should do for an X-ray, why CT, why MRI, when these things are required. So over to you, Dr. Brubin.
Hi, I'm going to explain the radiological investigations and modalities which is needed and which can be done for specific clinical aspects of the back pain. So I'll be discussing what are the different advantages and disadvantages of each modality, and coming to the first investigation, the X-ray, which has been there for decades, and every orthopedician, neurologist, everyone will look into the X-ray first to just localize where exactly the pathology is and correlate with the clinical aspects. So the you can see what you can follow specific protocol for specific part of the body. So coming to the lumbar region, where the lower back is we are concerned about, we are concerned about the alignment. We have to look for any disc, any fractures, any which collapse, anything is there. Then you have to look for any other relevant what is that, like this, any metastatic lesions, any other sacral lesions, anything is related, that you just overall screening only you will get from the X-ray. Then the second modality you will go into is the CT. CT, when compared to the X-ray, you are getting a better VRT reconstruction, that is a 3D reconstruction, you can get it from this, and you can confirm the findings of the X-ray, which all are we were getting from the initial X-ray assessment. So the advantage of X-ray over CT is which very quick and inexpensive, and it will be available in all the centers. And only the disadvantage associated with this, no, it's very limited in the characterization of the low back pain, because the lumbar area, it is a complex bony structure area. So you have to look into detail of each bone, the nerves, whatever structures there. It is very difficult to see from the X-ray. When coming to the CT, this it's very good for the assessment of the fractures or any collapse kind of things, which is related to the bones, but the soft tissue detail is very less. So comes the MRI. So MRI is the most, ideal investigation which is required for the each clinical aspect of the lower lumbar region, which will be superior to all the other investigations, and this will give each and every details like disc, the nerves, the spinal cord, rather than just giving the bony information. So only thing we have to know is that if there is any metallic implants or anything, that will be a contraindication for some person, but still we can do based on the type of implant used. So coming to the first investigation, the X-ray. First you have to look at the X-ray, how the bones are there, the alignment. So you have to follow the different columns what ma'am told in anatomy, these different columns, the anterior, middle and posterior columns, and follow the borders of the vertebra all the way below to the sacral region. So if you follow this level, you have to identify that the alignment should be perfectly going down till the sacrum. If any change in the alignment, you have to suspect for any listhesis, any fracture, anything. Then locate the pathology, and then go into the further investigation based on correlation with the clinical aspect. So here also in the AP also you have to look for the different structures, the transverse process, the interspinous, posterior spinous, then the lateral columns, then the pedicles, all these things you have to follow. Then finally you have to reach the sacral region. Sacral region, the L5 vertebra and sacral bones will be difficult to see in AP. You have to screen it on the lateral X-rays. Then additionally finding you can get is the sacral sacroiliac joint. So if any sclerosis, widening, anything is there, then that management goes to the sacroiliitis pattern. So these are the things what you will see. First is the superior and articular process, that is what ma'am told the anatomy. So that you have to follow in each vertebrae till the L5 vertebrae. Then the pedicle, whatever is there. If any one pedicle is missing or anything, then you have to suspect if some lesion or something is there, focal lesion, which is near the pedicle, like metastasis or any other tumors or something. Then this level, more information you can get from the lateral. So lateral you can get additional this foraminal level, which is more clinically relevant. So most of the lumbar pains and all will be related to the nerve root compressions or kind of disc space reduction and all. That will be more typically characterized on the lateral. So you have to follow the columns one by one, and you have to look at the additional intervertebral foramen, then the posterior spinous process, lamina, pedicles, again till the sacral base. Now going to the further investigation. Once you characterize where and locate where the pathology is, and you are suspecting something clinically and relating to that, then you have to go and confirm the same with the other further investigations like CT or MR. Usually, typically MR directly, because most of the advanced latest MR machines will have additional sequence which can create CT kind of image based on the T1 sequences. So there is no additional benefit of doing CT over MR. So mostly you will go for MR concerning because most of the pathologies are related to the soft tissue and nerve roots. So first we have to go along the alignment. Alignment, what I told, the X-ray you have to look for the columns, if any listhesis, any break, any loss of lordosis, anything is there. Then you have to confirm with CT. CT will give the bony aspects more. The first one is the routine plain sagittal section showing all the lumbars and sacral bones, and second, the image attached to that is the bony window, which will concentrate only on the bone window, bone intensity. So that also will show any erosion, any fracture, any collapse of the bone. The last one, you can see the MRI, which shows the detailed soft tissue structures in the lumbar region. So from from the bone, from the bony aspect to the canal details, the spinal cord, the caudate nerve roots, epidural fat, the longitudinal ligaments, whatever it's already discussed in the anatomy, all you can see in MR in detail. So you have to look first all these things you can combine and see. If any doubt is there, you can go to the X-ray and correlate with that. You can go to CT correlation if you are not, if doubtful in the MR and like that. So alignment first you have to do. So from the CT sections, one additional benefit you can get is VRT, that is like volumetric reconstruction. So you will get a 3D image. You can plan for the surgery or other details, and you can see any kind of fractures you can characterize well if doubtful and all. Here you can see a compression wedge fracture, which is seen in the X-ray as a wedging and the disc phase reduction here. Then CT it shows the same. So you can compare the anterior and posterior columns. The height of the anterior column is less and posterior column it's more. So it's like a wedge compression fracture. The VRT also shows the same, and MR you can see how it's exactly the disc is associated, disc is affected if any posterior repulsion of the fracture fragment is there into the spinal canal, any cord compression, anything, that details you will be seeing in the further segment. So first you have to screen the alignment in all these things. So this is the line, this is the posterior ligament line, I mean like posterior longitudinal ligament line. So you can follow it, you can see here one fragment is going beyond the posterior ligament, so that you can get the CT images done. If you that same thing you can see as going a fragment going into the spinal canal, and this is a VRT reconstruction showing the fractured segment, and axial section showing the fragment going into the posterior spinal canal. So you have to characterize further. You can see any other soft tissue is there, any abscess is there, any disc involvement is there. That is better done by the MR. So here you can see the sagittal MR section T2 weighted image. Here you can see this is the spinal canal. It's a cord, and this is the posterior bulge of the segment into the spinal cord, means spinal canal. Then you can easily characterize if it is compressing the cord, any cord signal changes are there, edema is there, all these things you can characterize, and if any infective osteomyelitis, spondylitis kind of thing, or any paraspinal abscess is there, if any other vertebra is having some early changes without any collapse, those things you can characterize from the MR. And the axial sections also confirm the same. There is posterior compression causing the canal narrowing and cord compression. So coming to the alignment, the first thing you have to look for is the listhesis, I told. So listhesis also you can get characterized based on the grades, how much percentage is getting slipped off. You can grade it into 1, 2, 3, 4 and complete slip off. So that also you can characterize from CT and MR both. But in the pars defect, which is the posterior pars is the supporting structure, that is usually broken, then only the listhesis will be higher grade. So when pars defect is there, the MR will be very difficult to see sometimes, because the bone characterization is not that great in the MR section. So in that cases CT will be very helpful. That's one thing what I told. Like now the latest MRs will have CT, synthetic CT reconstruction, so no need for extra CT or radiations. Now the part of the alignment, you have to follow the posterior structures will be all piled up together in the X-ray. So X-ray, the finding the posterior structures are a difficult and a challengeful thing. So here is one thing, very famous thing, that Scottish dog appearance, and you can see here the nose of the Scottish dog is corresponding to the transverse process, and the eye is the pedicle, and the ear is the superior articular fossa, and the front leg will be the inferior articular process, and the lamina will be the body, the posterior leg will be the spinous process. So if you follow the same, you can get a spatial orientation of the each anatomical structures in the lateral X-ray. So if you find something one of these things abnormal, then you can suspect that thing and confirm with the further investigation. So sometimes this listhesis, whatever happens is due to interarticular pars defect and all. So you can see a defect in the neck of the Scottish dog appearance or whatever you follow. So if that's called collared Scottish dog. That means it's abnormal and listhesis should be suspected. So that's what we are seeing here. Here, this Scottish dog, this neck of the region, neck of the dog is showing some band. That means a lucency. There is a bony defect there. Then these are the same thing. Whatever I am showing, this is also again a pars defect which is shown. It's anteriorly there is some sclerosis also on one side, and other side particularly seen. This side particularly is not clear. So when you took the CT, you saw the pars defect on one side, other side some sclerosis. In MR, you will get the further details of the. This is what I told. Like the pars defect will be very subtle in the MR. So this is where you need a retrospective view of the CT to confirm the defect. And the spinal canal, other things, and neural foramen you can characterize well in the MR. Now going to the bone. These are the ABCDs I am explaining. The alignment, bone, cord, and degenerative changes are this. So bone, coming to the bone, bone you have to look for any lesions, specific lesions like osseous hemangiomas or anything. Usually in hemangiomas, this coronal, the CT will show a polka dot appearance in the axial sections, and sagittal and coronal sections of CT will be jail bar appearance. It's like vessels and lighting areas. So that same thing which you see in MR, it will be a T2 bright lesion. And similar to that, other changes in the bone include degenerative disc changes, end plate changes and all. These are age-related things. And then coming to the most malignant features. Malignant features kind of bony marrow infiltration in multiple myeloma, other bony mets and all will be characterized in the bone, should be characterized in the bone. Now going to the cord and canals, you have to look at the X-ray. First what I told, the column you have to follow. The posterior column, you are suspecting something, you have to either you have to do a CT or a MR. If you have fractures, CT will be helpful more, and but MR is unavoidable because you have to look for any retropulse fragment which is causing any compression or not. So here this is the cords, this is a canal. Here you can see the this will not come on. Okay, basically this area you can see there is a disc bulge, but it's very difficult to understand from the CT images. But when you go to the MR, you can see there is disc bulge easily from the T2 images. This is T2 image, T2 weighted image, and this is a T1 image, weighted image. So T2 weighted image, all the water structures will be bright. So this the spinal cord CSF will be bright, and this is the T1 image. The CSF will be dark. So characterizing this disc bone things, everything from the different sequences of the MR, you can come to a conclusion where what is happening with the spinal cord and spinal canal. So coming to the axial view also, you can characterize these are the traversing nerve roots, whatever ma'am was telling. And this will be the exiting nerve root, and this will be the foraminal zones. So here you can see here's a good CSF within the cord. Here you can see the compressed cord with crowded nerves. So again, coming to the canal stenosis, you can again grade it based on how is the sac space and character. So this all will be in the axial sections, and this all will be in the lateral sections. Sagittal sections. So sagittal sections, you can look at the foramen, neuroforamen. So neuroforamen, there will be a keyhole structure with an exiting nerve root in the center and the fat pad. So you can see if any part of this getting outloaded, then you also suspect different grades of neural funnel narrowing and code compressions. So same way in the axial sections also, the traversing the roots and other CSS spaces you can see. Based on the compression and neural spinal canal narrowing, you can grade the severity of the thing. Now going to the D part. D is the disc or degenerative part. So this degeneration, every human will towards the aging they will develop osteophytic changes and disc degenerative changes. So you have to suspect that as the other changes which is associated with the lower back. So in the X-ray you can suspect all these things. If you can see that there is sclerosis, osteophytes, and disc space reduction, all this can be degenerative changes. So the same thing, if you go into CT, you will get a better picture and better characterization. Even here also you can see any other irregular facet joint hypertrophy is there or not, any disc space reduction is there, any osteophytes is coming and compressing the posterior thickle sac and all. And you can confirm the same and code indentation and nerve pathologies from the MR also. So this also have different grading based on the desiccation changes. Desiccation means like whatever ma'am told, like the nucleus pulposus and annulus fibrosus part of the disc you have to assess. Usually it will be like hyperintense signal in the water content will be there in the nucleus pulposus region, and towards the periphery it will be the annular fibrosis. So it's type 2 collagen. So that thing it should ideally should be seen like this. But when you see an desiccated disc, that means the loss of water and degeneration is going on. Here you can see the disc is dark, the height is lost. All this points to the disc desiccation changes, and the grades of that is also based on different parameters. So grade 1, 2, 3 higher degeneration, it can get further complications. So this is a pictorial thing which is telling the same. Normal disc should be of same height and all. The disc will show the loss of water signal. This degenerate disc can get bulged into the canal. So bulging disc, and sometimes it will herniate when the base is small and the prolapse part is more. Then it is called herniated disc. Then it can be thinning of disc. It can be osteophyte formations also. So this is a cross-sectional image. So these different areas are there. This is the same thing we are seeing. This is a spinal canal. This is a spinal canal. So this will be the exiting nerve roots, and this will be the traversing nerve roots going along. And these are the degenerated disc and all, which will come bulge here, and will cause the compression of the exiting nerve roots. And here also this osteophytes can come and cause osteophytes and flaval ligaments can come and reduce the spinal canal dimension, which will cause cord compressions and canal narrowing. So different zones are there. Based on that, you have to characterize for what is happening. So the central part is called central canal, and just behind the articular process, it is called subarticular zone. Then beyond that, it is divided into two zones, that is foraminal, extraforaminal, and anterior zones. So sometimes what happens is like the disc will get sequestrated after herniation and all. It will get sequestrated, and this sequestrated thing can go into either of the compartments. Either here, it can go here. It can go into the foraminal zone, extraforaminal zone, and all and causing compressions. So but that can be seen well in the MR. Now this is another image showing the collapse of a segment with destruction of the vertebral, two of the adjacent vertebrae and the disc. And there is a large soft tissue also in the anterior aspect of the vertebra. It's just you can see the stretching of the anterior longitudinal ligament also. So there is something coming from the vertebral destruction and occupying the anterior. This is a case of TB. So another thing This is another case which is showing a different multi-level involvement of the bones. So this is a case of metastasis. Here also this cord, you can see metastatic lesions in the cords. And this is a case of osteomyelitis. You can see the vertebral body enhancement, marrow changes and all. So these are the main things you have to be looking into the radiological aspect.
So thank you, Dr. Bibit, for that explanation of the imaging. Now we have Dr. Jim, who is a professor of orthopedics, here to explain regarding the clinical aspects and how to do an examination in case of a lower back pain. Over to you, sir.
Thank you. So, after the anatomy and radiology presentations, let's get into the clinical aspect of low back pain. So, when the term low back pain comes to our mind, most of us tend to think about disc, and disc is only one of the causes for low back pain. The commonest cause of low back pain is usually the mechanical back pain, which is usually associated with prolonged sitting, unaccustomed postures and all that. Disc disease, definitely yes, it is one of those causes where you can have back pain, but also important to know that disc is not the only cause for back pain. You can also have pain from the facet joints, and osteoporosis is usually a very unrecognized cause of low back pain. Many of our elderly women do have osteoporosis, and it is often not looked into. And rarely you can also have back pain which can come out of non-spinal causes like an abdominal aneurysm or a pancreatitis, a renal stone. All those things can be causes of low back pain. So in this picture, if you look at, we have already had the radiology class. You can see that there is a disc extrusion out here. There is a significant amount of canal stenosis, and in this picture you can actually see that the right sided facet joint is actually quite hypertrophic and it is bulging into the neural foramen. But images are images, you always have to correlate them clinically. So many of our back pains are usually mechanical or postural, and it does not really need immediate investigations. Many of them will get better with some simple measures like analgesics and rest. But there are times when you really want to start investigating immediately, and those are the red flags. So these are the conditions where you wouldn't really want to wait. You will start investigating immediately. So the first one is extremes of age. Elderly patient who is coming to you with a new onset back pain needs immediate attention. And back pain is quite uncommon in children. So when a child complains of back pain, usually it is quite significant. And when a patient who has an associated leg pain, which might tell you that there is a amount of neural compression going on, that is something which needs to be investigated. Most of our back pains usually get better with rest. So many of our back pains, after a good night's sleep, it will get better. So if the pain is persisting at night, it means it is significant. When a patient has had a prior history of malignancy, a tumor or an infection, you are slightly worried that the tumor might be coming back. So that is one place where you would like to investigate. Some of those drugs like long-term steroid intake, patients on long-term anti-epileptics might have might have osteoporosis, and these are the patients who might have small fractures. So you need to investigate them as well. So also patients who are immunosuppressed, these are the patients who can have infections. A history of trauma is also very important. When you have a history of trauma, you would want to image immediately. And whenever there is a patient who is not responding to non-normal treatment, you want to investigate them further. So this picture is a picture which you will often see in the clinic. You can actually see that the patient's trunk is tilted to the right side. This is not a scoliosis, this is a list. A list is usually seen in a case of a disc prolapse or anything which actually presses on the nerve root. So it is very important to start looking at the patient right from the time they walk into your clinic. You look at their posture, look at their gait pattern. Tenderness is sometimes elicited, but to be very frank, you cannot really palpate anything very deep inside the spine. You can only palpate the spinous process. So if you have an active infection going on, you might have some amount of tenderness. But usually tenderness is not a major factor. You would like to look at the range of movement. Don't look at the range of movement alone. Also look at the way they are bending. Do they have pain on flexion? Do they have pain on extension? All these are important. And you would want to add to do an SLR, straight leg raising test, which will tell you that the nerve root is at some pressure, there is a nerve root compression. And because sacroiliac joint is very commonly confused with low back pain, so you also would like to check the sacroiliac joint stress test. And without me saying, you know that a neurological examination, a thorough neurological examination is very important in any cases of low back pain. So how do we manage them? So I have actually purposely put a question mark at rest, because the role of bed rest is very debatable. Many of these patients do not need enforced bed rest. If they want to take rest, that is fine. And if they get relief with rest, that is also fine. But you don't really want to force them to take bed rest, because prolonged bed rest is usually associated with loss of muscle mass. So you really don't want the patient to lose the muscle. So analgesics can help. So can physiotherapy, which the PMR department will be talking to you about. These are the things which you can do in the acute stage. But then your aim is to prevent a recurrence of back pain. So for that, you probably need a good posture. You need some regular physical activity. It can be walking, it can be swimming, it can be dancing. And you would want them to start some spinal exercises, which our PMR department will explain to them. And if the patient is overweight, you want them to start weight reduction also. So regarding surgery, so there are very limited indications for surgery in a back pain. So most of the back pains usually we treat if there is a very identifiable cause of back pain. So you need a cause for back pain, and you should have the symptoms which correlate with the images. Only then the treatment becomes surgical. So when you have, commonly you can have a disc prolapse which presses on the nerve. You can have radicular pain, the leg pain, and those are the patients who might need surgery if they fail to improve with non-operative treatment. The other indication is usually this, when there is a large instability. If you look at this, you can actually see that the L4 body is actually slipping right in front of L5. It's a spondylolisthesis. These patients have instability, they have severe pain. Those patients usually respond very well to procedures like lumbar fusion. And if you select them properly, if you correlate the clinical symptoms with the imaging, and if you think everything tallies, then they might be a good patient for surgical correction. So basically what I want you to take home is that in spine examination, in low back pain treatment, a good clinical examination is extremely important. Do not depend on investigations or images alone. You always correlate the patient's clinical examination with the investigations. And always important to treat not the symptoms. Like you might have a patient who is an IT professional who might want to sit long time, and that is producing pain, and it is unable to do that. So you would want him to start exercises, you would want him to get up once in a while. You can probably treat his disability better than the symptoms. And whenever you plan a surgery, always make sure that you counsel them very well. Thank you.
So thank you, Jim sir, for that short and sweet presentation on clinical examination and how to go about with the patient with low back pain. And now the most important part, the rehabilitation part, and we have Dr. Anandaraj from the Department of Physical Medicine and Rehabilitation to explain it. Over to you, Doctor.
Good afternoon. So I'll be discussing about low back pain rehabilitation. This would be a simplified version of how we go about with rehabilitation of a low back ache patient. So the rehabilitation approach is basically it's a comprehensive approach to
aimed at reducing pain, improving function and preventing recurrence. So basically the most important aspect that we'll be focusing on is function. Just like Jim sir said, we should always aim to reduce the disability rather than treat the symptom. So our focus will be on improving the function of the patient. So at times the patients will be having condition for a long period, like more than 6 months or more than a year. So what happens is that the patient's condition has a tendency to get somatized or centralized, which means that even if the cause of the pain in the spine or the lumbar region is corrected, the brain has engrammed the pain signal, which is always present, and this is called as chronic pain. So in such cases, the treatments, all the medications are all bound to fail. In such situations, we should be focusing on improving the function of patient rather than rather than completely curing the patient of symptoms. And another aspect is to prevent recurrence of symptoms. So it involves a combination of medical management, which includes drug therapy, injections and everything, and physical therapy, which includes exercises and physical modalities, and lifestyle modification, which is quite important in case of chronic low back ache. And the advice is to continue ordinary activity as early as possible for quick recovery, rather than to ask the patient to take bed rest. Like sir said, if the patient wants rest, they can take rest, but we should not enforce rest for this patient. So the term that we use is relative rest. If the patient is able to do an activity without stress or without any difficulty in the pain-free range of motion, that should be advised and encouraged. So it reduces non-use syndrome or deconditioning. So what happens when a person goes for complete bed rest is that all the muscles that are responsible for stabilizing the spine will get deconditioned, which further results in further more worsening of symptoms. So at best, we should be encouraging the patient to do all the activities in the pain-free range of motion. So coming to pain management, the most important thing is that initially we start with medications like non-steroidal anti-inflammatory drugs. Then muscle relaxants, the role of muscle relaxant is debatable, but there are patients who get some improvement with muscle relaxants. Then we go for neuromodulator drugs also, which include non-benzodiazepine anticonvulsants like pregabalin, gabapentin, all these drugs. And certain patients might require antidepressants like tricarboxylic acid. This also prevents the pain into becoming chronic. So most of the patients who come in for rehabilitation will be having long-standing pain. So those patients might benefit from antidepressants, but it is not indicated in case of an acute pain or a subacute pain. It's not necessary at all. So we don't have to give such patients all these medications. And there are opioids given for low back ache also, but it's not widely used in our country. Then we resort to physical modalities. So the aim of rehabilitation is to bring down the use of drugs and help the patient take non-medications or non-pharmacological methods to improve their symptoms. So we make use of heat modalities, cold modalities, and ultrasound, which also one mode of action of ultrasound is by generating heat deep within the tissues. So we make use of all such modalities to improve the symptoms of the patient. And but the problem with these physical modalities is that it only just improves the symptoms for a short span. So by the time we should give other methods of management also as an adjunct or as an adjunct to improve the condition of the patient. So we can use these medications to medications as well as the physical modalities to bring down the symptoms. By the time the patient should be adequately rehabilitated with exercises and functional movements. Now coming to injections. So, like Sar said, most of the patient that come with low back pain doesn't have surgical cause, or most of these patients will be having problems that's not related to the disc or the vertebra. It's mostly the muscle tissue or the muscles. So there is a condition called myofascial pain. So lots of people will have trigger points in the muscles. We call that as myofascial points. So this is basically because of imbalance of muscles. Certain muscle fibers will become taut band, and that results in painful points in the muscles. So because of this pain, the patient will resort to awkward positions or awkward ways of walking, and that increases the imbalance, and that would result in further pain. And this is one of the most common causes, and we can classify it under lumbar strain, muscle strain and ligament strain. And epidural steroids, most of these injections are given for radiculopathy kind of issues. And then physical modalities. So cold therapy or cryotherapy. So basically cold therapy is indicated in acute conditions where there is so much of visible inflammation and pain, and it's also given for muscle spasms also. And examples are ice packs. So this is an example of ice pack and cold compressors. Then we have heat therapy. So heat is mostly given for subacute and chronic conditions. So this is in general. This relaxes muscles, improves the blood flow, and reduces pain. So example is the usual cold packs hot packs that people use, and then heat wraps, paraffin bath, etc. But the disadvantage of all these methods is that it will give heat only superficially. So for giving heat to deeper tissues, we have to resort to diathermy or modalities like ultrasound therapy, which uses high frequency sound waves to heat deeper tissues as well as accelerating healing. Then we have another method called transcutaneous electrical nerve stimulation, where low voltage electrical currents is given to the skin, given over the skin. So the purpose of this is this electrical current will stimulate the nerves, and based on the gate theory, this will result in decreasing the conduction of pain signals to the brain. So this is a technique that we can employ for all chronic pain conditions. But the disadvantage is that the pain will recur or come back once the effect of the stimulation is gone. Then other physical modalities include laser therapy, where we use low level laser light or low level laser to stimulate tissue repair and reduce inflammation. Now this new term is photobiomodulation. Okay. Photobiomodulation. And it is hypothesized that laser light will stimulate the mitochondria and will bring in biochemical reactions that results in tissue repair. But the evidence is relatively poor at this point of time. Now we have interferential therapy, where we use electrical currents to reduce pain as well as muscle spasm. The advantage is that like ultrasound, this helps in heating the deeper tissues. Now coming to exercises. So this is a general guidelines for exercise for low back ache. The exercises can be classified into flexibility exercises, strengthening exercises, then balance exercises, endurance exercises. So basically flexibility exercises is stretching of the muscles, and strengthening exercise in case of low back ache, we concentrate on the core muscles, which is the muscles of the abdomen as well as the back. And aerobic exercise is for is for improving the endurance of the patient. So core strengthening exercises, we focus this exercises can be classified into level 1, 2 and 3. So the basic exercises include pelvic tilt, bridging and plank, which I will demonstrate later. Then flexibility exercises include cat cow pose, knee to chest, hamstring stretches. So before we resort to these exercises, we will have to do a thorough examination of the patient to see what are the muscles that are weak, what are the muscles that are too tight, and the gait pattern of the patient, and based on this the exercise prescription is given. So this is a general exercise guidelines, but for every patient the exercise should be customized. So back extension exercise includes Superman technique. So this is back hyperextension exercise. Then we have aerobic exercises that we can ask the patient to do: swimming, walking, cycling, all this. So these are a representation of the common level 1 and level 2 exercises that we ask patients to do. And then lifestyle modification. This comes particularly important in case of chronic low back pain, where we educate as well as encourage the patient to bring down their weight to adequate or optimum BMI. So maintaining a healthy weight reduces stress on the spine, as well as gradual weight loss is suggested through diet as well as exercise. Then posture and body biomechanics. So proper posture while sitting and standing and lifting. So those people who are employed in jobs that require lifting of heavy weights need to be taught about the proper lifting technique. And those who work in work in jobs which require prolonged sitting requires training or requires educating how to sit properly while they work. So all this should be given to the patient. So most of the common problems that we usually see when we look at people who sit continuously is slouching posture, bending too much, twisting motions, all this. So all this needs to be corrected. And exercise and physical activity. Regular physical exercise strengthens the core muscle, so it improves the flexibility and reduces pain. So we can also ask them to do low impact exercises like swimming, walking, yoga, all this. Then ergonomics, like I said before, we should ensure workspace is set up for good posture. So it includes desk setup, the chairs, and all the things that would affect the posture of a person in his workplace as well as at home. And we need to teach them to, or make it a habit to take short breaks in between. It is said that at least after 55 minutes of constant sitting, we should take 5 minutes of break, and this is called as micro break, and during which we can do a few stretches to increase the blood supply to the tissues that are fatigued. Then stress management. Stress has an important role in chronic pain conditions. So with increasing stress, the muscle tone will also increase, which results in increased tightness of muscles. So these all could aggravate the condition. So the people could be taught relaxation techniques like deep breathing, and those chronic pain patients would require cognitive behavioral therapy also to bring down their anxiety level, so that this could improve their pain condition. Adequate sleep is also very much important for muscle recovery, because fatigue requires adequate nutrition and adequate sleep for recovery. Then smoking cessation. Smoking is found to worsen back pain as well as any painful condition, so this should also be considered. Braces are needed only when it is very much necessary, because unless it is indicated, if we suggest bracing for a person, that could decondition the muscles that support the spine. So if there is more harm if we do not prescribe a brace, only in those conditions we should suggest a brace. So interdisciplinary rehabilitation. So rehabilitation, as I said before, it's a comprehensive method, so it includes a lot of personnels. So the approach is to manage chronic low backache that involves collaboration of multiple healthcare professionals. So it is basically a holistic approach, and it addresses physical, psychological, and social aspects. So without considering the social aspects of the patient, rehabilitation wouldn't be complete. So roles include physicians who diagnose the underlying cause, prescribe medications, monitor the progress of the patient, manage pain through medication, injections, and other interventional procedures. And then physical therapists who focus on improving the strength as well as the flexibility and posture correction. Psychologists and psychiatrists might be necessary in case of chronic pain to improve the psychological condition, to improve depression, anxiety if the patient has that. Then occupational therapists assist with activities of daily living. So like I said before, improving the functioning of the patient, decreasing the disabilities of core importance here. So improving the activities of daily living is very much important, and modification and pain management strategies. So benefits of interdisciplinary rehabilitation, it's a comprehensive care, improves the outcome, reduces reliance on medication. So we have to bring down the use of medications as far as possible. So comprehensive interdisciplinary rehabilitation will suit that. Enhanced patient satisfaction. So this multidisciplinary team provides support and encouragement, so better satisfaction. So the importance of patient education and self-management. So this empowers individuals to take control of their own condition, reduce reliance on healthcare professionals, and improve overall quality of life. So for example, for a chronic pain, the patient might require the assistance or might want to consult the doctor quite often. So to make the patient independent and to reduce the reliance or the need for a physician, we need to educate them about their condition and the self-management strategy. So patient education is to help them understand the condition. So most of the patients have fear avoidance behavior. So because they have lots of misconceptions about their low backache. So like Sir said before, most of the people has the concept that all the low back pain is because of a problem with the disc. So they will be confused, or they will be so much concerned if they do some activity, it will increase their disc problem. So we need to educate them about the spine, about their own spine, about the conditions that they have, and what are the problems that may cause an issue with them, and most of the conditions won't be affecting, or most of the activity won't be affecting or worsening their condition. This need to be given to the patient, and we need to discuss about the prognosis to reduce anxiety, as well as the various symptoms that he might encounter. This should also be discussed. Then dispelling misconceptions. So correcting misconceptions about bed rest, spinal instability, and overuse of imaging technique also need to be discussed with the patient. Then encouraging physical activity. So that is very important to, but it is very difficult to implement also. The compliance is very poor. Then promoting healthy lifestyle, emphasizing the role of weight management, good posture, ergonomics, and for preventing back pain. Self-management strategies is all that I have discussed before. Again, pain management techniques, we need to teach them how they can themselves make use of relaxation techniques to relieve pain, heat and cold therapy by themselves at their own place, and over-the-counter medications only when it is very much needed. Then exercise and movement, providing guidance for exercises. So exercises, there is a common guidelines, but based on that we can teach them certain exercises that they can use at all times. So basically it involves strengthening the core muscles and improving flexibility and mobility. Ergonomic adjustments should be taught. Then pacing techniques, coping strategies to manage stress and anxiety should also be taught. So this is a general idea about how we go with chronic pain, low backache management.
One of those tests that you might want to remember is the straight leg raising test. SLR, as we commonly call it, is a test which is used to assess nerve root tension. So it is fairly a simple test, but we need to understand that to have a positive SLR, you are actually going to look at whether there is pain on the leg. A back pain is not a positive SLR. The positive SLR is when you have actually pain radiating down the lower limb. So when you have a patient, you should always explain to the patient that what you are about to going to do, and always do, like, imagine this subject's pain is on the right side. You always do it on the normal side first, so that he knows what he can expect. So I'm going to do a small test for you. Just let me know if you have pain. So what I'm going to do is to gently lift his leg, see how far I can go. Like here he is able to do it very well. He is going right till about 70-80 degrees, which is quite normal. So on the other hand, if you have a patient who has got disc extrusion or anything which is compressing a lumbar nerve root, SLR is usually positive in those patients who have a lower lumbar neural compression. It is usually not positive in higher lumbar discs, which usually are very rare. In those cases, you need to do a femoral nerve stretch test. So that is done prone, which is not very important at this moment. So SLR, when I do on the affected side, usually the patient will complain of pain when they reach somewhere around 30 to 60 degrees. That a recreation of pain along the lower limb is very significant, and when you say positive SLR, that is what it means. Very often some of us will have hamstring tightness, so when you do a straight leg raising test, you can have back pain, and that is not a positive SLR. And very often we are often confused with pain arising from the lumbar spine with pain arising from the sacroiliac joint. A very common test that we use is a figure of 4 test, which is the sacroiliac stress test. So for that, you again explain to the patient what you are going to do. I'm going to bend your knee and keep it on the other side. So this is what you will do, and gently stress the knee and see whether he has got any pain. Always when you do this test, you observe the patient's face. You don't really look at the leg, you should look at the patient's face whether he is wincing with pain.
Teaching you a few level 1 exercises for low backache. So this exercise is called pelvic tilt. Okay, so what I am going to do is you have to flex both your knees. Please flex both your knees. Place it. Now place a towel underneath your low back. Okay, so I'm just keeping my hand underneath. Okay, now you will have to ask the patient to straighten their low back such that it compresses the towel, or in this case my hand. Okay, just press it down, just press it even more. Yeah, now I can feel the pressure. So this this position has to be held for 5 seconds. 1, 2, 3, 4, 5. Relax. Please press it again. 1, 2, 3, 4, 5. Relax. Okay, so this is pelvic tilt. The second one is called bridging, where the person has to lift their gluteus or the buttocks up, or the hip up. Please lift it up. Yeah, and he has to hold this position for 5 seconds. 1, 2, 3, 4, 5. Down. Lift it up. 1, 2, 3, 4, 5. Down. Now the third test, the third exercise is called knee rolls, where the person should be placing both the legs together and moving both the hip towards one side, and you'll have to hold this position for 5 seconds. 1, 2, 3, 4, 5. Now bring to the other side. 1, 2, 3, 4, 5. The last one, place it straight. And you'll have to lift it up. No, just one leg. Lift it up. Okay, 1, 2, 3, 4, 5. Down. Lift it up. 1, 2, 3, 4, 5. This you'll have to do only in the brain-free range of motion. You don't have to lift it up if you have severe pain. Down. Okay, just lift it up. 1, 2, 3, 4, 5. Lift this up. 1, 2,
3, 4, 5.